Welcome, and thank you for coming out tonight for the Arthritis Society, the most exciting time ever in the history of the treatment of rheumatoid arthritis. We appreciate you coming out to tonight's event. My name is David West, and I have the privilege of being your MC tonight. My full-time occupation is as a senior consultant and partner with Mercer, which is a global consulting, outsourcing, investment consulting firm. My specialty is in employee benefit programs. I've been connected with the Arthritis Society over an extended period of time and in many different ways. I have suffered with arthritis since my late teens. 17 years ago, that unknown arthritis was diagnosed as rheumatoid. And since then, I've been further diagnosed with psoriatic arthritis. So I'm one of the 3,400 Canadians with both forms. It is with the support of the Arthritis Society that I educated myself on what that diagnosis was likely to mean to me. When I realized how severe the disability could become, or the disease could become, I decided to support the Arthritis Society financially. Excuse me. Lost my spot. As a donor, I help fund research to find a cure and to continue support programs for the over 4.5 million Canadians that suffer from one of the over 100 types of arthritis. I've also had the distinct honor this year of joining the National Board of the Arthritis Society. As the title of this evening's event says, the most exciting time in the history of the treatment of rheumatoid arthritis. I firmly believe it to be true. I wouldn't be here or at work today without the help and support of so many, including family, friends, colleagues at work, my employer, and the Arthritis Society. If you haven't been on their website, go. It's a fabulous resource. I also know that biologic drugs form a big part of my treatment and maintaining my abilities to do the things that I do. I have been on one for 10 years this month. While biologics are very effective for many in the treatment of arthritis and rheumatoid arthritis in particularly, we still need to find a cure. At this point in time, I have the great privilege of introducing Mary Kim, an arthritis self-management program leader and master trainer in Toronto. Mary?
Thank you. You have no idea how unnerving it is to go before Ed Keystone. Because I know all of you are thinking, what is she doing up there? Get it out here. I want to hear it. Well, to be frank, so do I, actually. And I'd like to tell you a little bit of myself. When I was 24, some years ago, oh, right, it was 26, okay? 26 years ago. See, I'm not as young as you think I am. Anyway, I decided to do a career track change. I went into the hospitality field. I wanted to be an events planner. And I had a job lined up after my course was ending. And unfortunately, I also came down with rheumatoid arthritis. And as my course was ending, I realized there was no way I could do a job in events planning. I could barely stand for more than 10 or 15 minutes at a time. It was not feasible. So I looked for other things. My arthritis was very fast and furious. And at the time, it was in '85 that I was diagnosed. I was on Atropine at that time, which was aspirin, which didn't very help. And so I looked for something. with my looking for other doctors, looking for other solutions. And I did find a doctor who finally got me onto gold and prednisone and got me into remission for about a year. But there were some missteps along the way. Partly, those missteps were made by my doctor, and partly by me. Because at that time, I didn't really realize that as a patient, I had some responsibilities. And those responsibilities were asking questions and asking for options. And because of that, again, I flared, and I've never really recovered from that. And within 3 years of my diagnosis, I was using crutches. Within 4 years, I was basically bedridden. Within 5 years, I was going through my first joint replacement surgery. Between 1990 and 2000, I went through 8 joint replacement surgeries over 7 joints. I stand before you with 2 artificial knees, 2 artificial hips, 2 artificial shoulders, and a left elbow that's been replaced. In 2000, I had to get my left knee redone. And I was looking at the other, my right knee done. Finally, my doctor and I decided that I'd go on a biologic. And that gave me 4 years of non-surgical time. And believe me, I enjoyed every second of those 4 years. I thought I was let out of jail. Unfortunately, then I developed an infection about a year after the last joint replacement. And so the last 5 years have been rather challenging. As it was pointed out, to live with this and to deal with this, you need a lot of help. My prospect was that I was never really going to have a career. I was never going to be able to hold down a full-time job, and so I had to look for other option. One of my options was, what? Lie in bed all day, twiddle my thumb, watch TV? You know, for me, that was not an option. So I decided to look at the Arthritis Society, see what they had to offer, and maybe, just maybe, I might be able to do something for them as well. I started out at the information line, and in the information line, I learned 2 very critical things. People did not know a lot about arthritis. I was just amazed, the lack of knowledge. What really frightened me was doctors did not know a lot about arthritis. That really scared me. And I'm going, something has to be done. What is this? And the Arthritis Society kind of came up with 2 solutions. One was the ASMP program, the Arthritis Self-Management, which taught people not only knowledge, because knowledge is great, but knowledge without application means next to nothing. The ASMP program taught me how to apply the vast amount of knowledge that I had gained over the years on a day-to-day basis to get through my life with this disease. And then another organization that partners with the Arthritis Society called Patient Partners in Arthritis taught me how to do a physical exam on the joints, like a GP might or a family doctor might detect whether there are signs of arthritis. So using my body as a teaching aid, and that knowledge, I demonstrated the exam to med students, to family doctors, and to other health professionals. And then I realized there was one very important component for people who weren't doing enough, and that was the government. And I realized to my horror, up to that point, the government has not given 1 cent to the Arthritis Society for research. And so with another organization that was nurtured and funded for the first 5 years of its life, the Canadian Arthritis Patients Alliance, I got involved with other arthritis patients to lobby the government for more funding for access to medication. You know, a few years ago, I was talking to somebody and they asked, I was at an arthritis event, and yes, I do go to a few of those every once in a while. They asked me what I did. And so I said, well, I work with the Arthritis Society, and I do this, the arthritis, and that, and they looked at me after asking a few questions, and they said, you know, you have a really interesting career. And I stopped for a second, and I thought, Yes, I do. During those depressing times when I didn't know what to do with myself, in a society where an adult worth is measured by their career choices and how well they do at their career, not to have one can be crushing. Then all of a sudden I realized, with the help of the Arthritis Society, I did have a career. I did have worth, and I had been able to contribute. So I'm here today to thank the Arthritis Society, everybody that works for the Arthritis Society, for the support for the last 15 plus years. Not only supporting me, but giving me the opportunity to support them. And also people like Dr. Ed Keystone, who tirelessly has worked for years trying to find a cure or better treatment every step of the way. They've actually made my life complete, and for that I would be grateful. And today I would also like to thank especially the supporters of the Arthritis Society, because without you, there would not be an Arthritis Society. And believe me, I have no idea where I'd be right now. Thank you.
Dr. Keystone is a professor of medicine at the University of Toronto. He is a senior consultant in rheumatology at Mount Sinai Hospital. He is the chairman of the Canadian Rheumatology Research Consortium, a national network of scientists, of academic and community rheumatologists devoted to enhancing the scope and efficiency of clinical trials in Canada. In 2003, Dr. Keystone established the Rebecca MacDonald Centre for Arthritis and Autoimmune Disease, a center devoted to research into genomics, therapeutics, and outcomes in autoimmune inflammatory joint disease. He is currently director of the center and heads the Advanced Therapeutics Division, which focuses on novel therapeutics in rheumatoid arthritis. Dr. Keystone was an Arthritis Society research grant recipient from 1977 to 1990. And we thank him for joining us today to share his expertise on rheumatoid arthritis. Dr. Keystone.
So this is to remind everyone here that without the support of the pharmaceutical industry, particularly the companies that are named here, we wouldn't necessarily be here tonight. And I just want to comment right off the bat that the pharmaceutical industry gets a bad name, and lots of people say they're a real problem. I just want you to remember this. Who is going to provide the new therapies for arthritis? It's not the government. It's not the university. It's the pharmaceutical industry that has made the difference in this country and around the world. So yes, there's issues, but without them, you wouldn't be where you are today with rheumatoid arthritis. So I just want to tell you that they are very important in the improvement and, in fact, in the scope of what has happened in arthritis in the past 10 to 15 years. So I want to thank them for doing what they do best, which is creating new therapies. So I just want to put that right on the table for you. Okay. So, I said this is the most exciting time ever in the history of the treatment of rheumatoid arthritis, but I must tell you, it is the most exciting time in the treatment of all inflammatory forms of arthritis, not just rheumatoid arthritis. It has changed the face of arthritis care in the last 10 to 15 years. So the first question is, what is arthritis? So let me just remind you again, arthritis is heat, redness, pain, and swelling. In Latin, it's rubor, calor, tumor, dolor. That's how we kind of remember it. And I think the way to think about arthritis in general is it's like a fire in the joint. It's like a burn. And that burn is continued, and the fire continues because your own body releases the oils onto the fire to keep the fire burning. And it's our job to put out the flames, to put out the fire by reducing the chemicals that are released by your own body, which are driving the inflammation and driving the problem. So, what is rheumatoid arthritis? Before I tell you that, I have to remind you, there are 115 kinds of arthritis. So you can't just say, I have arthritis, because there's 115 different types of arthritis. And in fact, rheumatoid arthritis is a so-called autoimmune disease. Auto means self, immune means the immune system. And it's a problem in which the immune system is effectively attacking your own body. It's sabotaging you. And in fact, there are 50, count them, 50 autoimmune diseases currently been described. 50. Rheumatoid is only one. There are 2 million Canadians that have these forms of arthritis. Rheumatoid is the most common of the most severe forms of arthritis. And that's why a lot of attention has been paid to rheumatoid arthritis. But there are many other forms that can have joint destruction, damage, and disability. Rheumatoid is only one. What do we know about rheumatoid? Well, simple. It occurs all over the world. Everywhere in the world, every country, every population in the world has rheumatoid arthritis. It's not specific just for the north or the south, it's everywhere. 1% of the population, 1 in every 100 individuals, 400,000 Canadians have rheumatoid arthritis. And it does usually affect people between the ages of 40 and 60, and it doesn't matter what your race, what your color, what your creed, we are all susceptible to rheumatoid arthritis. And it's mainly women that have it, more women than men, 2/3 women, 1/3 men. What people forget is this isn't an old age disease, because I'm older than 60. I don't want to admit that very often, but I'll tell you that. And 40 to 60 is the young people who get rheumatoid arthritis. But there are children, there are about 7,000 children with juvenile rheumatoid type arthritis, and their arthritis starts between 6 months and 2 years of age. And when they have it, they're devastated, because if their joints become involved and altered, it's a lifelong sentence for those individuals. And what we treat and how we treat adult disease, we treat children the same. So what we learn about the adults, we use for the children as well. So we have been making great strides over the years. So how do you make a diagnosis of arthritis or rheumatoid arthritis? That's easy. We are all trained in medicine to say we do a history, we ask the patient some questions, we do a physical exam, and we examine the joints, and then we do laboratory tests. And that's how you make a diagnosis. In terms of history, it's usually pain, swelling, and stiffness. Now, for rheumatoid arthritis, I will never make a diagnosis without a patient with joint swelling. You may have pain, you might have stiffness, but unless the joints are swollen, I personally, and most of us, would not make a diagnosis of rheumatoid. So joint swelling is an important part of rheumatoid, but so is the arthritis of psoriasis. You have to have joint swelling usually in order to make that kind of diagnosis. The question is, what joints are involved in rheumatoid? Because there are 68 joints in the body, just 68. Hello. There are 68 joints in the body, and there's certain joints in the body that are usually seen in rheumatoid arthritis. So here you have this little, we call it a homunculus, and we all have a stamp. Can you imagine writing out each joint that's involved? It'd take days, months, and years. So we have a little stamp, and we put on the stamp which joints are swollen, which joints are tender, and we use that in addition to asking the patient how they're feeling and how they're doing as a guide to therapy. Now, for rheumatoid arthritis, it's usually the small joints of the hands and feet. And hopefully you can see that. My little pointer won't work because I got to point both ways, and I won't quite make it. So you'll see hands, you'll see feet up there. I hope you can tell hands from feet. Okay, I'm sure you can. And out there you see the small joints of the hands, and usually the big knuckles, the metacarpals, and the middle knuckles of the hands are involved, and the feet, small joints, symmetrical, both sides, hands and feet are usually, not always, but usually what rheumatoid arthritis presents with. So you examine the patient and you look for joint swelling, heat, never redness in rheumatoid, because red joints mean something other than rheumatoid. Rheumatoid joints don't become red. The arthritis of psoriasis, you can have red joints. You can have infectious red joints. You can have gout and have red joints, but not in rheumatoid arthritis. So if a rheumatoid patient came to me and their joints was red, swollen and red, I'd wonder about infection number 1, 2, and 3. It's very uncommon to have these red swollen joints in rheumatoid. So, joint examination. Obviously, we feel the joint, and I'm just going to show you, this is the left-hand side when they present, that is when they come to us, they're swelling, and notice the big knuckles are swollen, and the middle knuckles maybe as well. So we feel for fluid, and if there's fluid and bogginess, and if there's mushiness, I mean, that's not exactly a medical term, but if there's that kind of thing happening, then you would say, gee, you have inflammation in the joints. If it's bony hard, you say there's maybe not inflammation, that's damage. But when it's mushy, when it's soft, and it's boggy, we say you have active inflammation in those joints. So that's the physical exam. And it's interesting because Canadian physicians, fortunately, actually have learned that joint examination, in addition to asking the questions about the patient, is very important. And I'll tell you why. Swollen joints will damage over time. Tender joints will not. So even if your joint's tender and painful, you will not damage over years. If your joints are swollen, regardless of what the pain is, you can come in with and saying, I'm great. In fact, I have some people in the audience who I know well here who come into my office all the time and say, I'm fantastic. And I say, no, you're not. You're not fantastic. You're a lovely person, mind you, but you're not fantastic because you have swollen joints. And swollen joints damage no matter how you feel about them. So we, as Canadians, fortunately, really count on ensuring that those joint counts, that is, the joint is swollen or not. Okay, another concept is the concept that rheumatoid is not just a joint disease, it's a systemic disease. You can come in with fever, and fatigue is one of the major problems in rheumatoid arthritis, anemia. Your muscles can be involved, your nerves can be involved, your heart can be involved, your lung can be involved. You can get nodules or lumps or bumps on the elbows, on the ankles. Fortunately, for reasons that aren't entirely clear, rheumatoid has become more mild over the last 20 or 30 years. 30 years ago, when I practiced, we had 40 beds at Wellesley Hospital. 40 beds, and 2/3 of those beds had patients with rheumatoid in them. We now have 6 beds dedicated to arthritis in all the city. In the entire city, they've cut rheumatology beds because they need more. You know, as the hospitals shrink, we're the first to go. They now have 6 dedicated rheumatology beds in the entire city. We had 40 back when I first started. Now we have 6. So things are different. Things have changed, and we don't need those beds as much anymore because of what's happening. The only side effect that I'm worried about most, or I think about most, these days, outside the joint, is actually the lung. The lung is an area that can be involved in rheumatoid, and that's probably the only area that we see at least some of. Not a lot, but we still see lung involvement in rheumatoid. Heart, almost never. Nerves, occasionally. Muscle, not very often, but certainly lung occasionally does occur. So what about the blood test? Now, I love this, you see, because a patient comes to me from a family doctor and says, well, you know, rheumatoid factor is seen in rheumatoid arthritis. And if I don't have a rheumatoid factor, the patient can't have rheumatoid arthritis. And if my sedimentation rate, which is a test for inflammation, isn't up, and my CRP, which is a test for inflammation, isn't up, you couldn't possibly have rheumatoid arthritis. What they don't know is that about 40% of people coming to the first time to a doctor with rheumatoid won't have a rheumatoid factor, which is a blood test for rheumatoid. Therefore, the tests are irrelevant. What matters is the history and the physical. 95% of the time you make the diagnosis without a lab test. Lab tests are nice to have. Rheumatoid factor, however, is seen in a whole bunch of other conditions. So a new test was developed a few years ago. It's called anti-CCP. And that's kind of, I don't even like to say what it means because half the time I can't pronounce it. It's anti-cyclic citrullonated protein. I did it. I've been practicing. Anti-cyclic citrullonated protein. I can't get the word citrullonated out. It's like the new therapies. Wait till I tell you some of those words coming out these days. So that's a new test for rheumatoid. Why is it different? Well, first of all, it's seen as much as you see rheumatoid factor. So early on, about 60% of patients will have this test positive. But if you have this test, you have rheumatoid arthritis. There's almost no other illness, not lupus, not psoriatic arthritis, not any of the other forms of arthritis that have this test positive. So in 95% of the cases, if you have this test positive, you have rheumatoid arthritis. So that's kind of nice in a sense, because now we have more definite diagnostic tests and criteria for rheumatoid. What's even more interesting is 15 years in many patients, 15 years before the onset of your arthritis, this blood test became positive. 15 years before. And then over the 15 years, the blood test gets higher and higher. 5 years before, your immune system changes. You don't have any joints. You have no problem. But you look at your immune system, things are happening. Those chemicals I talked about are actually being produced. So suddenly you have more of these chemicals that are causing inflammation, except there's no inflammation yet. And the antibody keeps going up, and then you get rheumatoid arthritis. Not in everybody, but it implies that we will know in a proportion of people who's going to get rheumatoid arthritis. So there are studies now going on called preclinical arthritis. Let's find out who's susceptible. Let's look at the children of those people with rheumatoid and find out if they have the blood test and follow them along. And in the next few years, the next year or two, we hope to develop an early, not an early arthritis, but a pre-arthritis clinic to see if we can spot those people. And why do we want to spot them early before they get the disease? We want to shut it off before it starts. We want to prevent. And that, we believe, is still possible even today. So it's kind of exciting. I think it's exciting, I don't see anybody sleeping here, so that's pretty good. So the question is, what's the treatment? So a caveat, which is really critical. The most important thing to know about rheumatoid arthritis is that you have to be aggressive in the treatment early. Why? Because there's early changes in the joints to the point where you become disabled, not as much as before. X-rays change pretty rapidly, or did, up so that they say that 95% of people within the first 2 years have damage on their X-rays. That's what used to be. I'm not sure it is today. And there is a mortality rate. That is, people can actually die of rheumatoid arthritis, and they said, 15% of your life is less. You lose about 8 years of your life if you have rheumatoid. And you say, well, why is that? And the answer is, any illness that causes inflammation in your body, I don't care where it is, whether it's the bowel or whether it's the joint, any inflammation that's chronic in the body predisposes to strokes and heart attacks. The chemicals that you produce in the joints are the chemicals that cause hardening of the arteries. They are the ones that actually drive strokes and heart attacks. So if you treat rheumatoid and you put it under control, and if you treat many forms of arthritis that are going on all the time, and you lower the level to close to remission or remission, you literally will reduce strokes and heart attack possibility. Important concept, a very important concept we've learned in the last 5 to 10 years. So then there was something that we learned and just shocked me to death. I must say, I was really surprised. I have lots of shocks in my life, but this was one of them. And that is, they did a study where they took people 4 months after they had symptoms. Not diagnosed. You know how long it takes to diagnose. You see a doc, he says, come back. You're too young, you don't have arthritis. Finally, you make the diagnosis, that's 3 months. Then you see 3 or 4 months to see a rheumatologist, and 7 months go by. This study took patients from 4 months from the time their joint hurt. Only 4 months. And they looked at their x-rays, and they were normal in about 90% of people. Then they looked at the MRI. The MRI, and there's high sensitive imaging, and the MRI was positive in 50% of the people. They had joint damage already in 4 months. What does it mean? It means that before you ever had a symptom, the inflammation was underground, it was there, and it was damaging your joints even before you had the first pain. So rheumatoid, by the time you get to the doc, is already getting a little late. It's not like it's the day it started. It's been going underground before you have your first symptom. That was scary. And once we realized that, we said, aha. We do say aha. Occasionally, aha. I think we should be more aggressive and we need to treat people aggressively. So I say rheumatoid is a medical emergency. When I used to say it to the emergency docs, they just rolled in the aisles. Oh, give me a break. Rheumatoid an emergency? For us, it's an emergency. And aggressive therapy is the right way to go, because the truth is, the earlier you treat, the easier it is to put you into remission. The later you treat, the harder it is. So the sooner you get to your doc and the sooner that therapy goes and is used, the faster you're going to get into remission, and therefore your long-term outcome is going to be much better. Truth. So we're talking about the past, we're talking about the present, and we're talking about the future. So what's in the past? Well, the past we use what's called conventional medication. Conventional means you use disease-modifying drugs, and I'll show you that. So this little fly-in, I had a little triangle fly-in. I didn't do that. I wouldn't know how to do a fly-in if I tried. But this little fly-in shows a triangle. At the bottom of the triangle, you have, physiotherapy, occupational therapy, education, all appropriate. Then you use an anti-inflammatory. And an anti-inflammatory like naproxen, Motrin, Telectin, all of Indocin, all of those guys, and there's about 24 of them on the market, they reduce pain, stiffness, improve your quality of life, but they do not change what's going to happen to your joints. And they work quickly, so within 3 weeks, if it isn't working, throw it out. It's not going to work. Fast-acting does not change what's going to happen to you. Lots of them on the market, and they're important, but they don't change what's going to happen to you. Now, on the other hand, after you've tried anti-inflammatories, and if you've got a diagnosis of rheumatoid, early on you want to use a disease-modifying agent. It's called the DMARD, D-M-A-R-D. These are the slow-acting drugs that take weeks and sometimes months to start to work, but they stop the progression of the disease, or they at least slow it down. So you have the NSAIDs, non-steroidals, and then you have the DMARDs, and it's the DMARDs that we need to use to stop the damage progression. And you'll notice up there and close to the middle, the lower part of the triangle, you've got gold therapy. Gold's great, you give it in your seat, and then when you pass away, somebody melts you down, and then you're worth a fortune, an absolute fortune. And actually, because I started rheumatology, I started practice in 1976, but in 1974 we were using a lot of gold. So we had a lot of rich people walking around the ward. And gold was one of the best medications we ever used, because when it worked, and it didn't only work only worked about 25% of patients, but when it worked, it shut it down, and it shut it down for years. And I still have patients on gold today after 30 years. So that's gold. But it's got lots of side effects, so we worry about it. And then there's Plaquenil, hydroxychloroquine is called, sulfasalazine, which is a sulfa drug. And they all work to some extent, but not most wonderful. And then finally, you have the gold standard these days in rheumatoid arthritis, and that's called methotrexate. Methotrexate is the drug of choice in rheumatoid in moderate to severe disease. If you're mild, you use Plaquenil, but if you've got moderate to severe disease, you go on to methotrexate. It is the drug of choice. And about 90% of all my patients are going to be on methotrexate. It has side effects. Some of them people don't like, and we can talk about those, but the truth is it is a disease modifier. It is a disease modifier. And then you've got other ones up on the top. You have cyclosporin, nobody uses it. Imuran, nobody uses it. Gold, nobody uses it. What you really have these days for rheumatoid is about 3 conventional drugs: Plaquenil, sulfa, and methotrexate. Those are the 3 drugs that we have that are really being used for rheumatoid arthritis today. Okay. When do you start a DMARD? The day you make the diagnosis. Not a month or 2 later, because every day that goes by, you risk the increased possibility of damage and deformity. So, what is the goal of therapy? It's easy. We are trying to maintain and improve the quality of life of our patients. That's the thing up there. It says HRQOL, quality of life, health-related quality of life. So how do you improve the quality of life? Well, you reduce the symptoms, make them feel less pain and stiffness. You stop the damage and destruction. You improve their function, and you allow them to participate either at work or at home with their family. I mean, that's the name of the game. Quality of life is what we're trying to do. Now, the problem is, the main problem in quality of life, and that's making it difficult, is inflammation or active arthritis, active disease. Redness, not redness in rheumatoid, but heat, swelling, pain, and therefore disability. So what happens with inflammation? Well, have a look at this. You see here the rheumatoid disease activity. So your arthritis is active. What does it do? Well, number one, it causes problems maybe with your lung, maybe with the nerves, maybe with the skin. You get these nodules. And on the right-hand side, it says comorbidities. What does it mean? It means weight gain because you're not able to get up and move as much. It means strokes and heart attacks. That's part of the, quote, comorbidity of rheumatoid arthritis. And then what happens is that active disease causes damage, joint damage. And joint damage to the right on that screen of yours, the problem, I like to look your way, but you know, when I do, I lose the voice a bit, so I'm trying to, I'll stand over here and do this. Okay, better? Okay, because I feel badly, you know, I'm ignoring you, but I'm really not ignoring you, honestly. So what happens is the damage causes disability, disability affects quality of life, and disability costs money. That is, and then medication costs money. So the name of the game is to prevent irreversible disability. You reduce inflammation, you reduce disease activity, you reduce damage, therefore disability, therefore you maintain your quality of life and improve your quality of life. That's what we try to do for a living. So what's the ultimate target? What are we really trying to do? I told you we want to improve your quality of life and maintain it. What's the target as a rheumatologist I'm looking for? And I want to tell you, that target is only 12 years old. But because before 12 and 15 years, this target was impossible to reach. We never thought we'd be able to reach that target, and it's easy. The target is remission. In 2010, we can put people into complete remission. Not everybody, but we can do that. 15 years ago, 12 years ago, we did some. We don't do as much as we do today. So now our target isn't, I'll make you feel better, I'll reduce your swelling, I'll get you walking a little more. It's remission. No inflammation of the joints, no progression of disease, no increased disability, and improving your quality of life. That's what we're doing today. Our target is very different than it was 12 or 15 years ago. So how good are we at it? Well, if you look at that circle, you'll see that up until about 6 or 7 years ago, the average percent of people we could put in remission was 25%. Maybe 30, but usually 25 or 30% max could we put into remission. It's not a lot. That means 2/3 were active, 1/3 was remission. Not a great track record. Question, can we come closer to remission? Can we do better than we did in the last 5 to 10 years? And the answer is yes, we can. So we have new strategies to make it better, to really put you into remission. We don't put everybody in remission, but we certainly increase the probability. So what do? We treat the day you make the diagnosis, you start a DMARD. It's called early use of disease modifiers, first. Secondly, we start to use the dose of methotrexate that should have been used years ago. Fortunately, Canadians, again, are really good rheumatologists because we started in Canada using a higher dose of methotrexate long before anybody else in the world. Then we use subcutaneous methotrexate, injections under the skin once a week. And I know it's a pain, but in fact, I actually learned to do sub-Q injections on myself, and it wasn't as bad as I thought it was. In fact, I managed to do that. Fortunately, I only needed to do for a week or two, but still I did it, or I found it was not so bad. And virtually everybody could learn to use sub-Q methotrexate if they want, that is injections under the skin. Why did I use it? Because every dose over 15 milligrams by mouth means there's less methotrexate in. By the time you get to 20 milligrams, you're not really getting 20 milligrams by mouth. By the time you get to 25, you're even getting less in. Every dose above 15 milligrams, less comes in if you take it by mouth. When you use sub-Q, higher dose, less toxic. Less toxic, yet it's a higher dose because it doesn't go through the liver, so you have less liver problems, you have less nausea. But the other side effects may be the same, but at least your liver isn't as concerned, the nausea isn't as concerned, and generally you get a better response. So most of us are beginning to use subcutaneous methotrexate more often than anybody else. We're still using it way ahead of the United States They're still on the pills. We're actually moving to the injections if we can. Finally, we use combination therapy, meaning we take Plaquenil, sulfa, and methotrexate, and we put them together. Or we use methotrexate and something else. And it turns out combination therapy is better than monotherapy. That is better than therapy by itself. Well, how do we know that? Well, think about chemotherapy. They take 4 drugs. They put them all together in a big gamish and they give them to you. They don't use 1. They don't use 2. They always have 3 or 4 medications. So we said, they know something we don't. So now we are doing that and succeeding. And finally, we have what's called tight control. It's called treat to target. Treat to target, that's the name of the game these days. And I just spent an hour and a half this afternoon with a group who are working on treat to target, which is what we call tight control. And I'll tell you that in a minute. So how much success have we had in Canada, for example, in treating early arthritis? Are we still in the 25% remission rate? So fortunately, Vivian Bykirk at our hospital, she's now at Harvard, but she comes back and forth. Vivian set up what's called the CATCH cohort, and it was initially funded by Amgen, and thank you for that. It is a group of patients, 1,200 across Canada, 18 centers across Canada are seeing patients, new patients, within the first 2 weeks. Meaning the first 2 weeks, if you call up and the doc says, I think you have rheumatoid, you'll be seeing a doc in 2 weeks. That's the deal. 3 maybe. So every early arthritis center in Canada, the 18 centers, are pushing to see people earlier to treat them more assertively. And we are making a difference. And fortunately, I feel proud of that Vivian was my colleague at the Rebecca McDonald Center. She heads the program still today, and the main center for the CATCH cohort across Canada is the Rebecca McDonald Center. So I must say it's wonderful. And we are always looking for people with early rheumatoid because we want to get them in quickly and treat them assertively. You notice I didn't say aggressive. Aggressive makes people nervous. Assertive is better. Assertive is much better. So how have we done? Well, this is just the first view of how we've done in Canada. And you'll notice if you're using by mouth methotrexate, you'll see here about 40% of the patients get into remission. If you use subcutaneous methotrexate, it's up to 53%. And if you're looking for low disease, which is not remission, but it's pretty good, you'll see you've got 52% if you use by mouth methotrexate, and 67%, 2/3 of the patient using subcutaneous methotrexate will have a state which is a little, not quite remission, but still low enough for the patient to do pretty well. So we're excited. We're making a difference, and earlier is better. Okay, tight control. Well, you know what tight control is? Because you see it every day. You have diabetics, and you say, my blood sugar is 1 point up, so what do? You bring it down. You do it that day. You add something or change something to make sure your blood sugar is there. You have a blood pressure that's elevated. You treat to the target. Get their blood pressure to 120/80. Get the sugar down to a certain level. And keep changing as often as necessary to get to that target. Well, rheumatologists are a little slow, but they finally said, maybe we should treat to remission. The target's remission. Let's change frequently, or if not change the therapy, let's adjust the therapy frequently to get this person where they need to be in remission. So the question is, does tight control work? So they did a study. This is a study here. This is a study. You don't have to read that. I'll tell you all about it. The study says I'm going to take one group of patients and I'm going to treat them however they want to be treated. The doc says, I'll treat you however I do. They took another group of patients and said, we're going to do tight control. Every 3 months, if you aren't in remission, I'm going to either change the therapy or I'm going to adjust the therapy every 3 months. So they started with a little bit of methotrexate. They added some sulfa and Plaquenil. If you weren't doing well, they upped the dose of methotrexate. Then they did this, they did this. Every 3 months, they adjusted. The question is, at the end of a year and a half, what percent of patients in tight control, treating to a target, versus those that were just on, I'll do whatever I feel like, what percent were in remission in both groups? And if you look at the bottom line here, you'll see there that 65% of the patients with tight control went into remission versus 18% with the docs doing whatever they felt like. Huge difference. So today, it's treat to a target. That's why we have these meetings to figure out how we're going to monitor patients every few months and adjust their therapy until they're in remission. That's like blood pressure. That's like keeping your blood sugar down. It's now time for us to do the same. So that's the past. We still use methotrexate. It's the drug of choice. You start with methotrexate. If you have moderate to severe disease, you start with methotrexate every time. Then you now consider, if you fail methotrexate, depending what province you're in, or whether you have government insurance, or whether if you have regular insurance, that is, insurance from industry, then you could do what you want. But if you don't, you have rules. And the rules in Ontario say, I have to fail methotrexate for 3 months. I have to fail another drug called Arava or leflunomide for 3 months. I have to at least use a combination of therapy for at least 3 months. And if I do all of that, which takes about 9 to 12 months, then I can get a biologic, a new therapy. On the other hand, I can go to the insurance company and say, I failed methotrexate, can I get a biologic? The answer is yes. So there's a difference. Unfortunately, we're not all created equal. Did you know that? We aren't all created equal. So it's a bit of a problem. So what's a biologic? It's a medication created from living tissue, that's why it's a biologic, from living tissue, which is like a guided missile. It selectively targets the problems in the joint. It selectively targets. So what are the problems that cause rheumatoid? So this is a cartoon that says what it is. At the top, you see a blood vessel, that little long thing. It's a blood vessel. The cells are floating by. They're not going in the joint. They're having a nice day. Like me, they're driving too fast, but that doesn't matter. That's the story of my life. And so the cells are passing by the joint. Suddenly, something happens in the joint, and then the cells come into the joint from the blood vessel in the joint. And then the cells start talking to each other. You can see they're talking there up on the top. You have a T cell and a B cell. These are your immune cells. What's a T cell? T stands for terrific. That's what I call it, because it's the general of the immune system. And the T cell talks to another cell called the B cell. They're lymphocytes, immune cells. The B cell used to be called boring. I called it boring, because B cells just make antibodies. It's like a factory. Come on, factories are boring. The T cell is the general, and the B cells are boring. Suddenly, in the last few years, we learned the B cells aren't so boring. The B cells make the same chemicals as a T cell. Didn't know that before. The B cells actually get the foreign body or whatever is in your body, and they present it to the T cell, which then gets activated. So B cells are now beautiful. Before boring, now they're beautiful. So we have a terrific T cell talking to a beautiful B cell. And then those cells release chemicals, and those are the chemicals like the oils on the fire. And the other cells talk to each other. A T cell talks to another cell talks to another cell, and they're all activated in the joint. And they're all producing these chemicals that damage the joint. So what do you want to do to stop rheumatoid if you want to be selectively targeting the problem? It's easy. Prevent the cells from coming into the joint. If they don't come in, there's no inflammation. Number one. Number two, prevent the cells from talking to each other. If they can't talk to each other, they're not going to produce the chemicals. Number three, you prevent the chemicals. You actually get rid of the chemicals. If that's an oil, have a guided missile get in there and get rid of the oil. Lower the level of that oil that's causing the fire. Or you can even get down to the lining of the joint, which is, the lining is like having a balloon with a fur inside. That lining, the inside lining like your coat, that also gets thick and it produces all sorts of problems. So what you want to do is prevent those cells, again, from talking to each other. And you see those little green guys at the bottom, just near the joint. The joint is at the bottom. It's actually a bone with a little bit of cartilage. Well, what you want to do is you want to get rid of those cells or stop those from producing the chemicals which are damaging the joint. So there's a whole bunch of targets. There's the cells coming in the joint, prevent them from getting in. There's the cells talking to each other, prevent them from talking to each other. Maybe you should lower the level of those cells. Get rid of the chemicals. Somehow get rid of the chemicals causing the problem. And then finally, when you get down there, you can look at the lining of the joint and try to reduce that as well. Lots of targets for the biologics, which are selective for whatever you want to make it. An antibody, you can make an antibody against everything, anything. You can make it against a bacteria, a virus, a chemical, a cell. We can create antibodies against anything. What's an antibody look like? Very simple. It's got 2 arms and 1 leg. And the little arms, the little grabbers that hook on. So if I say a certain chemical is there, I'll make an antibody against it. It floats through the circulation like a guided missile, attaches to it, and removes it from the circulation. Very simple. That's the technology we have. So, having said that, cytokines, which are these immune hormones or chemicals, are released. What do they look like? Well, one of the key chemicals we've learned is called TNF, tumor necrosis factor. And what does TNF do? If you look at that picture, it brings cells into the joint. It activates the cells so they talk to each other. It causes the bone-eating cells to eat the bone. And essentially, it's the oil creating the fire. TNF is very important in many forms of arthritis. So what did they do? They made antibodies against the TNF. So the one on the left-hand side here, it's called, as you can see, it's called Enbrel, or it's etanercept. It's like an antibody, but it isn't. It looks like an antibody, but it isn't. And you give this under the skin once a week. And it goes in and it removes the TNF, lowers the level. You've got another one there called infliximab. That's to the right, which is Remicade. Remicade's given intravenously every 2 months. It goes in and removes the TNF. Now, the interesting thing about Remicade is it's 25% mouse protein, 75% human. So you say to yourself, oh my God, let me look. Do I have a tail? You know? And then one day I asked at a forum, I said, what do you think the major side effect of Remicade is? And someone said, I get cheesed off. And so I thought that was good. So I use that from now on. And then there's another one which is fully human, and that's called Humira. It's in the right-hand corner, and that's given sub-Q every 2 weeks. So these are given by injection because if you give by mouth, your enzymes in your stomach are going to destroy it. It won't work. So then you say, well, a new one just came on the block. It's called Cimzia or certolizumab. And notice on the right-hand side, it's not 2 arms. On the left-hand side, you see the antibody. On the right-hand side, you see only 1 arm. So theoretically, Cimzia is 1 arm going along and taking out the TNF. It's not 2. It's 1 arm behind its back. The problem is it's too small. And it's too small so you actually pass it out of your body. It doesn't weigh enough. So what do? You put these little dumbbells, these yellow dumbbells on it, and what happens? You weigh it down, now it stays in the body. Interesting what they weighed it down with. They weighed it down with a medication or a chemical called polyethylene glycol. And I don't know if anybody knows what polyethylene glycol is. It's antifreeze. It's not really antifreeze. It's like antifreeze. So what do I say? Think about it. Winnipeg, in January, I'm going to give this stuff to them, sub-Q, every 2 weeks, and maybe not only will their arthritis get better, they might be warm for the first time in their life. You know? I mean, it's possible. So I kind of like that concept, you know? And then finally, we have a new one called golimumab, which is called Simponi, and Simponi is given under the skin once a month. Once a month. So things are changing. We now have 5 agents that take the TNF out of the body, reduce the oil, reduce the fire. Now then you say to yourself, well, okay, but like, what's the difference? It looks like everything else. It's maybe better than methotrexate, maybe it isn't. Well, what have we accomplished? So let me show you. This is Remicade, and back about 12, 15 years ago when we first started to do the studies, unfortunately our center was involved in those studies, we gave 1 shot of it, it's intravenous, and within 24 to 48 hours, some patients jumped out of bed. They could comb their hair, brush their teeth. They could do just about anything in 24 to 48 hours. It was amazing. Not everybody. Some people it still takes weeks, but it's a rapidly improving agent. And so are all of them. All the TNFs improve. They start improving you within a few weeks. Not months, but weeks. And some of these, like Remicade, could actually start in days. And some of the others also, like Enbrel and others, they all can be improved. Some people, they wake up the next morning. They're not stiff, they're not sore. It's an amazing difference. It improves them at least as good as methotrexate, if not better, and it improves them quicker. So the joints go down, the swelling goes down, the pain goes down, they're better. And what about damage? So here on the thing you see a tall bar. That tall bar is when the patient's failing methotrexate, for example, and they're failing methotrexate, and that bar means there's a lot of damage going on. The higher the bar, the more damage. Look at the bar on the right-hand side, if you use a medication like Remicade, like any of the TNFs. 95% reduction in that bar. What does it mean? You've stopped damage in 95% of the body. So it means you prevent 95% of that progression from occurring. Huge, huge. So it stops damage virtually, it reduces symptoms quickly, and in some cases, this is another example of a Etanercept or Enbrel. On the right-hand side, you see a bar. Remember I showed you, the one on the left-hand side is methotrexate, tall bar. The one with the Etanercept is lower because you stop the progression. And notice the one on the far right. It's upside down. It's not going up, it's going down. How come it's going down? Because the X-ray at the end of the year was actually better than when it started. The X-ray at the end of the year was better than when it started. So we are not only stopping damage, but we are actually starting to change the body and actually allowing the cartilage to grow again, or at least the body to grow again to the extent that the X-ray looks better. So you're healing. I always said I wanted to be a healer. Heal, I used to say to my patient. Didn't work. Heal, I said. Well, now we've got medications that actually can heal. So it's kind of nice. Now, I've always said that TNF inhibitors, that means these 5 agents, are similar, but they're not the same. Now, I have a lot of personal experience in this. Similar, but not the same. I have a life experience like this. Why? Because I have an identical twin. So, similar, but not the same. There's the evil twin and the good twin. And my slide shows me as the good twin. And my brother has the same slide with the titles reversed. And people think that I'm a little nuts, and I say, listen, I'm a little nuts because for the first 6 years of my life, when I looked at my baby pictures, I didn't know which was me and which was him. Now, can you imagine looking at your pictures, not knowing who you are? No wonder you'd be crazy. So that's our problem. We didn't know who we were. Even my mother looks at the pictures, and she was not sure either, and that made me even more nervous. Okay. So what have biologics accomplished in other conditions? Is it just rheumatoid? No. It's ankylosing spondylitis, it's psoriatic arthritis, it's things like iritis, inflammation of the eyes, it's juvenile arthritis, it's Still's disease, which is a form of arthritis. It's also in Crohn's disease and ulcerative colitis. They have made a huge impact on Crohn's disease and ulcerative colitis, and also on all of these other conditions. Skin, psoriasis, the heartbreak of psoriasis. Dramatic improvement in psoriasis. So, and you know, it's interesting, you think psoriasis, give me a break, it's not so bad. The highest depression rate, the highest suicide rate, the heaviest patients of all patients are actually patients with psoriasis. They don't want to go out, they don't want to be seen, they get depressed, alcoholism is big, depression is big, so it is a serious condition. We think, a little bit of skin, who cares? Well, you try to put psoriasis on your face and be happy walking out the door. The answer is not so fast. So, new biologics that we now have available. I told you about the 5 of them, the TNF blockers. We have other things. We have something called abatacept, not abatacept. Everybody calls it abatacept. I mean, it's like shoe store. It's not abatacept. It's abatacept. And what does it? It's called Orencia. It's given IV once a month. And it's given in home, at the home. You know, the side effects are good enough, so a nurse comes in and gives you the intravenous for a half hour. And what does it do? It prevents cells from talking to each other. Remember I said I got to stop that? They stop it. Then there's another, and that's how it works. It prevents those cells from talking. And then there's rituximab. Rituxan. What is that? Well, I'll tell you, it's an antibody. Remember, B cells talk to T cells? This is an antibody that binds to the B cells, the factory, and lowers the level of those cells that are talking to the T cells. It doesn't take them out completely, but it lowers the level. And sure enough, how do you give it? 2 shots, 2 weeks apart, once every 6 months. And sometimes 2 shots up to a year. So it can work anywhere between 6 and 12 months before you need another 2 shots. Pretty good. And then you have cytokines, which are these chemicals. Well, we found out there's another cytokine, interleukin-6, TNF, interleukin-6, which is like TNF. And what happens with that? What does interleukin-6 do? It does exactly what the TNF did. Brings cells into the joint. It activates all the cells. It turns on the bone-eating cells that cause damage. It does one other interesting thing, which is really very interesting. We knew that many patients with rheumatoid arthritis are anemic. And no matter how we treated that anemia, we couldn't get it better. We now know that interleukin-6 causes a protein to be produced that prevents iron from getting into the body, prevents iron from being released from your cells, so you can't get better because your own body is not using the iron to make your blood count. So when you lower the level of interleukin-6 with this new drug called tocilizumab or Actemra, hemoglobin goes up in 2 weeks. Like, we couldn't do this before. Within 2 weeks, people that have what's called chronic anemia, anemia of chronic disease, that's what's called anemia of chronic disease, this medication in 2 weeks starts to bring your hemoglobin up. Because now the iron is released and from the cells, and now iron is absorbed into the body, and now your blood count goes up. Amazing. I mean, so we're really doing good stuff. I mean, not me personally, but somebody's doing it. So there are the biologics today. You can see them. There are 9 of them, actually 10, but one isn't working so good, so we don't talk about it. But on the top, you see there's the current ones, Remicade, Enbrel, Humira. On the right hand, you don't know that. These are the other names. In a university, if you give a talk at the university, you're not allowed to say the trade name. It's infliximab, adalimumab. And, you think these are tough. Wait till I show you the new ones. Adalimumab, I months to learn adalimumab. I practiced it in the shower, in the bathroom, in the car, practiced it everywhere. And the day it got released, it was called Humira. Why did I spend all this time? Wait till I show you the new ones. These are even better. So now you've got the TNFs. You've got 5 of them, TNF inhibitors. Now you have Orencia. Now you have rituximab. Now you have what's called tocilizumab, which is called Actemra. And all of these are 9 agents. And if one fails, you can use another. And if that fails, you can use another. Even within the 5 TNF blockers, if one TNF blocker fails, you can still use another and still have success. Amazing. So, biologics have changed the landscape of therapy, and they are the standard of care. They're the standard of care in rheumatoid. I'm sure I'm running way over, I always do, but I apologize. I don't really apologize, I just want to tell you that I'll be finished in a minute. So the future, and there's only a couple of slides. We have learned that if something turns on the cell, it has to send a signal from outside the cell to the nucleus, which is the brain center of the cell. So if a chemical like TNF gets to the cell surface, and then it turns on a whole set of enzymes within the cell, and if those enzymes are turned on right to the nucleus or the brain center, then those cells start releasing the bad guys, the chemicals. So if I could stop the signal from outside to the nucleus, then the cell can't turn on. And if it doesn't turn on, it doesn't release its chemicals. So they have found enzymes within the cell from the top to the nucleus which turn on like dominoes. One gets turned on, it turns on another, another, another. They have now found inhibitors or blockers of these enzymes, which are pills. They are pills. They are not biologics. And so, this just is an example. You see here the yellow is like TNF. It binds to the surface, and that's that little blue and red thing. And then it turns on one chemical, or not one enzyme, and then another enzyme turns on. And they're kind of cute names. One of them's called Jack. And so Jack gets turned on. Don't go there. And then Jack turns on stat. And then 2 stats get together. And once the 2 stats get together, you'll see it says 2 stats get together. Then they go into the nucleus, the brain center, and the cell turns on. So what do? You block Jack. You prevent Jack from getting turned on. That could have a lot of complications and consequences, but in this cell, it doesn't. So you stop Jack, and therefore the cell can't turn on. And what happens when you use a molecule by mouth, a pill, twice a day? You get the same results as all the biologics, except you get it quicker. The results seem to be that they act sooner, but they're a pill. So that's kind of interesting. So here's what I say to myself. I talk to myself because I'm used to talking to my twin, and I thought it was me anyway. So when you talk to yourself, what happens? I say that if they're called small molecules, which means they're really just chemicals. If these chemicals have a good safety profile, and they work as well as the biologics, then they will become the new standard of care, and they will change the landscape of therapy for rheumatoid arthritis. So now you ask me, when's it happening? Well, the first one will likely be approved in about 2 years. 2 years. Not 10 years, 2 years. And by 4 years from now, or 3 years from now, there'll be three of the small molecules, assuming they're safe and assuming they work. And so far they work well. The question is long-term safety. So, at the end of the day, what have we accomplished? Well, it's very simple. Look at what we've got in terms of medications. Notice from gold therapy, which is about 70 years ago, right up till now, you can see in all the little green guys, that's what's happened in the last 10 or 12 years. And before that, what happened? So let me say it. Before 10 years ago, for 70 years, or for, I think I said, we had 7 treatments over 70 years. 7 new therapies over 70 years, up until 10 years ago. Now, we have 10 new therapies over the last 10 years. That is a huge difference. That is an amazing, amazing ability for technology to do this. And I want to remind you, the Arthritis Society funds a lot of research. It asks in the research, what are the hormones causing the problem? What are the cells causing the problem? So because of Arthritis Society funding, we're figuring out what the new targets are. And once you've got the targets, you can make any antibody or almost any chemical against any target. So the society helps us decide what's happening, and then the pharmaceutical industry drives that and takes it further to bring a new therapy on the market. So we say thank you, Arthritis Society. You've been helping a lot. So this is my second last slide. So I know, it's boring. So what are we really changing? What is really the difference? And I'm going to show you this slide. People's hands and feet are beginning to look and remain normal, and that's a huge event in the life of our patients, in their quality of life and how they feel. So I started by saying it's the most exciting time ever in the history of the treatment of rheumatoid and other forms of arthritis. That's what I'm saying here. And I must say, I've been very pleased to be part of that process. I've been very lucky, and I really mean lucky, to be involved in the development of these new therapies. And it is indeed the most exciting time ever. Thank you very much. The question was, I've been on methotrexate for a long time. I'm in remission. Can I lower the dose? The answer is yes, in my humble opinion. Not always so humble, but in my opinion. And why do I say that? Because any medication you're on, if you're truly in remission, and I'd say you've got to be in remission for at least 6 months, even the biologics, I try to reduce them. I try to lower the methotrexate if you stay in remission. And I warn the patient, the first time you start to get worse or feel more pain or stiffness, you go back to your usual dose. I think everybody should be on less medication once they're in remission. If they're not in remission, you haven't got a hope in heck of actually getting that dose down. So that it affects all medications. I try to get the methotrexate down. I try to get the biologic down if you're doing well and in remission. Okay. Let's see. So one of the questions is, does rheumatoid arthritis escalate degenerative disc disease, I guess, for example, in the neck and the back? Rheumatoid never affects the back, period. You got a back problem, it's not rheumatoid. If you have a neck problem, it could be rheumatoid. And sure enough, if you have a neck problem and inflammation, we call it secondary, wear and tear arthritis can occur. So yes, osteoarthritis of the neck or disc disease, degenerative disc disease, you know what the discs are, little shock absorbers between the bones. They wear down, and they can wear down after inflammation. So absolutely, necks can get worse because of rheumatoid. And so what you have to do is you shut the illness down if you can. Yes, okay, here's another question. Is there the same research and changes for osteoarthritis versus rheumatoid or inflammatory disease? Well, remember, osteo is wear and tear. It's common, affects, by the time you're 65, at least 50% of people by the time they're 65 will have osteoarthritis. It's wear and tear, it's tough on the knees, it's tough on the hips. The problem is we have not made great progress in osteoarthritis. Not nearly the same as what we've done in rheumatoid, psoriatic arthritis, ankylosing spondylitis. We have a long way to go for osteoarthritis. Why? Because there isn't a lot of inflammation there. There's a little bit, it's wear and tear. So how you stop that has been a kind of a mystery for a lot of us. Okay, what are the side effects of biologics? There are about 8 or 9 side effects that we all talk about. But there's really only one that I think about, and that's infection, 1, 2, and 3. Because the biologics do increase the risk of infection. I'm not even sure they increase the risk more than methotrexate. I'm not even sure they increase the risk more than prednisone. But prednisone is the most common reason why people get infections. So if you're on methotrexate, which you usually have to be, and you add a biologic, and you're on prednisone, you can imagine your risk goes up in terms of infection. But we're not sure whether biologics themselves actually increase the risk. But when you put them all together, there's probably an increased risk. So what do I tell my patients? You have a cough, or you have a cold, I'm okay with that. You have a cough and you're bringing out yellow or green phlegm, I worry about that. You stop the biologic, you call your doctor, you see them immediately and get on antibiotics sooner than later. The other point is that it can reactivate tuberculosis. There's lots of people in this room who've had TB. You don't know you had TB, but you're carrying it. You don't even know it. Your x-ray won't show much. In fact, it'll be negative, yet you've been exposed to it. So it can reactivate tuberculosis. So we always do a TB skin test before, and I believe, and if it's positive, we put them on a medication at the same time as we use the biologic. And the other thing we do is we vaccinate them. I think everybody should get Pneumovax, which is a pneumonia vaccination. I think when the flu vaccine comes out, you should get that. And also, if you haven't had tetanus for 10 years, you should get that. And then if you're hepatitis, there's hepatitis B, and we always check for hepatitis B and C before you get methotrexate. And if you've never been exposed to hepatitis, so your antibodies against hepatitis are negative, that means you've never seen it, then we tend to want to vaccinate them for hepatitis B. So those are the things we do when you start a biologic. And we warn people about infection. Malignancy, everybody worries about malignancy, cancer. They all worry about cancer. To date, there's only one paper that suggests that cancer might be increased. Every other paper has not shown an increase in cancer to date. There is one cancer we do worry a bit about. It's called malignant melanoma. That's the one that we think it might be increased. It is a concern, but all of the other cancers, bowel cancer, lung cancer, etc., are not increased with biologics. But skin cancers may be increased, but those are the kind you can usually biopsy, take them away. Lung cancer is increased in rheumatoid, period. Lung cancer is increased in rheumatoid. Lymphoma, or cancer of the lymph gland, is increased in rheumatoid. The longer you have active rheumatoid, the higher the risk. Is it a big risk? No. So the risk of lymphoma in me is about 1 in 2,000, 1 in 1,500 people. The risk of lymphoma in rheumatoid on average is about 1 in 1,000. So yes, it's twice the risk, but it's still only 1 in 1,000. Still uncommon. The risk of solid malignancy or cancer in anybody in this room is now about 1 in 700. So 1 in 700 is pretty high. Lymphoma is less, it's 1 in 1,000. The sooner your arthritis is under control, the lower the risk of lymphoma. Okay, so that's it. Cancers, maybe, we don't think so. Infection, we think so. So that's what you think about. Then there's a whole bunch of other things that I'm not worried about. I warn the patients about, but I'm not very worried about them. Okay. I get scared for my methotrexate injections. No, I get scarring, not scaring, scarring. I understand scarring. It's a problem. Sometimes methotrexate is irritating enough to cause some scarring. I don't think it's going to go away so quickly. That's why you rotate the sites. You might do it in one arm or another. Maybe you'll give it in the legs, for example, in the thighs. That can be a problem, and I don't know how to get rid of that. The side effects of Humira, which is the anti-TNF, is exactly what I just said. Infection 1, infection 2, infection 3. And if you're traveling to a weird and wonderful country, in the back roads of a weird and wonderful country, just make sure that when you come back, because the risk of TB in Africa, China, India, East Asia, all of those countries have a high risk of tuberculosis. So when you're going to those countries and you come back, it's probably best to do your skin test again, your TB test, about 2 months after you get back. Can I get pregnant? Of course you can. Oh, that's not what they asked. Sorry, whoever asked it. Yes, you can. I don't even know you, and I think you could. Can I get pregnant? Well, I'm such a riot sometimes, honestly. I think I'm funny, but I'm not sure. Can I get pregnant while I'm on methotrexate? 9, no, nix, forget it. You don't get pregnant on methotrexate. Not a good idea. Humira, yes. You can get pregnant on any of the biologics, at least the TNF blockers, the abatacept, the Rituxan, and the Actemra. These are the new ones. We don't have enough data. We do have some data recently on pregnancies, which seem to be okay. The TNF blockers, yes, but not with methotrexate. Remember this, what we normally do. We say, go ahead and try to get pregnant. And then they say, I'm pregnant. We then stop the methotrexate. We stop the biologic, usually. And 65% of patients who get pregnant go into remission. So that's important. And then they flare afterwards. But I have patients that have active disease all the time, so I write them a note to their husband. Please make this woman pregnant, because then she's got a 65% chance. I mean, what other drug gives you a 65% chance of going into remission? So I've got one of my patients has 14 babies. Really. It wasn't me, and it wasn't my notes. But she's been pretty well for 14 years, I've got to tell you. I know, I said the same. She brought all her kids in one day. They were lining up from top to, you remember, what's that musical? Right, that's the musical, and they're all wearing the same clothes. Like they had, the boys weren't wearing dresses, but they were wearing the same colors, you know, and it was fantastic. Honestly, it was wonderful. So anti-TNFs, Enbrel, Remicade, Humira can all be used in pregnancy if you need it. Okay, and so if you flare, you put them on a little bit of prednisone. That's what we try to do to get them through the pregnancy. And sometimes we say, look, I'm going to put them on Enbrel through the whole pregnancy. I am not concerned about it, and recent data supports that. First of all, Enbrel doesn't come into the breast milk. Cimzia or certolizumab, which is the new one called Cimzia, we have recent data this year that says it doesn't get into the baby, it doesn't get into the mother. So if I had to choose one, I'd probably choose the new TNF. Remember the one that when you're in Winnipeg, you're warmer? That one. That one apparently says that it doesn't get into the baby or the breast milk, so that's one I might want to choose. Can you further explain how the lungs are affected by rheumatoid? It's a good question. First of all, what's very interesting is that I said this antibody, remember called anti-CCP, and I said it's found 15 years before? Smoking increases the anti-CCP antibody. So people who smoke have a higher risk of rheumatoid, and people who have rheumatoid have a higher risk of doing badly when they're smoking, because it increases that antibody, and when that antibody's in the body, it tends to cause damage. So why do you get lung disease? Because the immune system in the joint is doing the same thing in the joint as to your lung. So it's causing the same chemicals released, it's causing the same damage, and if you smoke, you have more of this anti-CCP. What is really interesting, in the last year, people are concerned that gingivitis, gum infections, may be one of the triggers for rheumatoid arthritis, because smoking increases the anti-CCP antibody, and if you biopsy the gingiva, you know, here your gums, you got anti-CCP there. And the bacteria seem to trigger this anti-CCP. So all I can tell you is make sure you brush your teeth. And remember, it's not just brushing, it's 2 minutes of brushing, 2 minutes by the clock, morning and night. And that, you know, who knows if it's going to make a difference. In the old days, people took their teeth out. Remember? They had crowns. No, remember I had the silver? And they said, oh, it's the amalgam. I'm going to have all my amalgam removed. Not my teeth, but my amalgams. They took out all the silver out of their teeth. Anyway, I don't think they're any better. But it's interesting that now we think that the bacteria in the mouth may, in fact, be a trigger for rheumatoid arthritis. Stay tuned. I'll come back in a year or two and we'll talk some more and I'll give you some more good info. Okay, upside down. Wow, this is a 2-hour question. So this is a patient who did really well, was on methotrexate and Enbrel for years, had no symptoms, so she stopped her medications, and she's still doing fine. And so that's great. Is palindromic rheumatism one type of rheumatoid? Palindromic rheumatism is pain in the shoulders and the hips, occurs when you're over 60 or 65. You ache, you pain, it hurts. A proportion of people with PMR, it's called polymyalgia rheumatica, PMR, I lied, that's polymyalgia rheumatica, PMR, and that can develop into rheumatoid. Palindromic rheumatism, that was the question, I don't read so good. Palindromic rheumatism is this. What is a palindrome? Does anybody know what a palindrome is? Well, you should all know. A palindrome is a word that starts the same and ends the same. Radar is a palindrome. Radar, R-A-D-A-R. Frontwards and backwards, it looks the same. So palindromic rheumatism is you have a flare of pain, swelling, stiffness coming on in 12 to 24 hours. It lasts about 3 days and it's gone. Acute, and then it's gone. And if it lasts more than 3 days, you don't have palindromic rheumatism. It starts the same, it ends the same, and it turns out it is a form of rheumatoid. 1/3 of patients get better for the rest of their life without treatment. 1/3 of patients continue to have it, and 1/3 of patients go on to rheumatoid. So palindromic rheumatism can be that. An acute, coming up, red, swollen, painful, oh, it's terrible, gone in 48 hours. If you don't have that, you don't have palindromic rheumatism. Oh, it's a good question. They asked the question about desferrioxamine used to remove the excess iron from joints with joint problems. There is a condition in which you can get too much iron in your joints, and you can have joint damage, liver damage, diabetes because of excessive iron. And we don't use desferrioxamine for it. What we do, it's called hemochromatosis. Hemochromatosis, we do what they used to do in the old days in the barber shops. We bleed them. We bleed them every month until their blood count goes down. And then they become a little anemic. That's okay because they had too much iron in the first place. So the treatment for that is, it's like the vampires. We bleed them every month or two until their iron goes down. It's a difficult disease to improve, but people do improve. But it's important because if the iron stays up, your liver goes, your pancreas goes, you get diabetes. It can be a tough condition. I don't recommend desferrioxamine unless you go to a blood specialist like a hematologist because I never use it. But we do use it in some conditions when there's too much iron. How do you reduce the dose of medication? How to reduce the dose of medication? It's easy. I do it slowly every time. I do it very slowly. I never stop a drug like that. Plaquenil you can stop because it stays in the body for months and months, so it doesn't matter. Methotrexate I would never stop. I try never to stop methotrexate if I can help it unless you're in remission, because even if you don't think that methotrexate is doing anything for you and you're feeling like, it's not that good, when you stop methotrexate within 4 to 6 weeks, you will flare generally badly. You'll have you say, wait, it didn't work very well. I'm still aching. You stop it, you flare, you say, it must have been doing something. Not true. It might have been doing nothing, but we know there's a post-cessation, a post-stopping flare that occurs with methotrexate. So I would rather lower the dose, keep you on it, add something to it, than to stop it because I worry about the flare that you get when you stop it. Slowly. Now, the question is, what should I stop first? I'm on Plaquenil and methotrexate. The answer is simple. I stop the Plaquenil. It's mild. It isn't a big-time drug. I won't do a lot for you. It'll help, but it's not going to stop the damage. Plaquenil does not stop damage that I know of. So therefore, I'd take you off the Plaquenil first. If you're still doing well, I would slowly, over months, not weeks, but months, taper your methotrexate. Good. How does sulfasalazine work? Interesting question. Sulfasalazine actually affects the cells from communicating. It affects the cells from releasing their chemicals. So it works internally within the cell, and it works in, sulfa works in Crohn's disease and ulcerative colitis, and it's kind of an anti-inflammatory that actually prevents the cells from releasing these chemicals. That's what it does. It's not the most powerful in the world, but it does work. Oh, stress and I knew they'd ask that. You want to know about stress? Talk to me. You want to know about lack of sleep? Talk to me. Does stress cause a problem? We used to believe, and there's still not a lot of great data, that just before rheumatoid starts, if you look back within the first 6 months before it starts, they said there's always a major stress. Someone died, you fell out of the boat, a fridge fell on your foot, something like that. So they say there's a major trauma or a major stress that triggers it. These days, people don't believe it. In my day, in the 70s, we all believed that was the case. We're not sure. Does stress cause a flare? You know what? No one has ever proved that stress causes a flare. And I'll tell you an interesting concept. When you're under stress, your immune system is really turned on. So in theory, while you're under stress, you should have a flare because your immune system's activated. And as soon as the stress is over, your immune system crashes. So think about when you get a cold or an infection. And the answer is you had a major stress for weeks at a time, the stress is over, and 3 days later you get a cold. And you say, I got a cold on my holidays. How'd that happen? Because during the week you're under stress, you had a holiday, your immune system crashes after the stress. We did the first studies, I'm proud, we did the first studies 20 years ago on stress and the immune system. So what do? We took med students just before their exam. No surprise. And we checked their immune system a week or two before the exams, and their immune system was going like gangbusters. And then right after the exams, we retest them about 2 weeks later. Crashed. Their immune system crashed, and they all got colds and infections. So we didn't know that there was that relationship, but years later they said stress actually is protective, and as soon as the stress is over, you're going to get infection, and that's when infections generally occur. So we were kind of the first. Then we tried to do it with accountants. So we took this accounting firm just before tax time, and we did the immune system. We checked it just before tax time, and guess what happens? Before tax time, it was up. During tax time, it was up. After tax time, it was up. The experiment was a failure. They never had less stress. And do you think an accountant is under stress? I can see before April 1st. I understand that. But after that, they're bean counters. Why would you get under stress counting beans? Well, I didn't mean that. You're going to take that away. Anyway, that's what happens. And we're shocked and surprised that their stress never came down. So that experiment didn't work, but the med students certainly did. Diet. Is there anything in your diet that can change your arthritis? Well, we don't think so, but if you think so, go for it. So what I mean by that is some people say, if I take some alcohol and I take some raisins and I add something into it, you have to be sober, But if you're not sober, I can see why your arthritis gets better. However, gin and raisins does not seem to work for rheumatoid arthritis. Diet does not seem to work. But if you say, every time I have tomatoes, my arthritis is worse, I'm not going to tell you. I'm going to say, don't take tomatoes. I'm a scientist. I have no idea. We tried all these things about diet. It never proved out. It doesn't mean there aren't some people where diet has an effect. So I'm easy. I'm not that easy, ask my wife. But I'm easy in the sense that you can do anything you want in my practice as a rheumatologist, but promise me you'll take the medications that we talk about, and we talk about it. I don't say you've got to do this unless I'm worried about you. And some patients listen, some don't. And when they don't listen, I have a great line. I say, look, and they don't take medications because they're afraid. So I say, look, this is great. Great. I'm going to learn the natural history of rheumatoid arthritis without medication. I haven't seen that for years. And then I say, look at my hands. I feel good. My hands are fine. So if you want to do what you want to do, go for it. You're an adult. You make your own decisions. I never kick people out of my practice who say, I don't want to take your medications. That's stupid. It's their life, their responsibility. All I can do is advise them. There you go. And we have a lot of fun in my practice. Any of my patients will tell you we have to have a laugh. No laugh, I kick you out of my practice. That's all there is to it. I don't want too serious. Life's too short for that. Okay. Bone loss. Yes, osteoporosis does occur with rheumatoid arthritis when it's very active. And as you get older and you've got active rheumatoid, you definitely should be looking at that. The risk of cancer with biologics, we said we don't think so. What are the new, oh God, somebody knows stuff. It must be one of my industry people. What are the implications of the new diagnostic criteria for rheumatoid arthritis? Isn't that special? Well, let me answer the question simply. As a rheumatologist who's in practice, nothing, generally, because the criteria are for clinical studies, they're for what's called epidemiology, outcome research. Now, if you want to be obsessive compulsive and you want to have criteria before you make that diagnosis, go for it. But when a patient walks in my door and their SED rate is normal, their rheumatoid factor is negative, but they've got 10 swollen joints, they have rheumatoid to prove in others, and I couldn't care less what the tests show. In fact, I hate to tell you this, but it's true. For years, and still today, I don't care what the rheumatoid factor is. I don't care what your SED rate is. I don't care what your CRP is. It's what you look like at the bedside that tells me how you are. If the blood test is wrong, throw it out. It's how I work. And 35 years, I've been in practice that long, I hate to say. I was 18 when I went into medicine, maybe less. Anyway, 35 years, I've used the patient as my yardstick. What they say, what I see, and if the tests don't work and they don't mean anything to, I don't use criteria. You know, I'm not obsessive. If you're well on methotrexate, don't ask for biologics. Only ask for biologics if methotrexate fails. That's the main reason for using biologics. But I told you, the government's not going to give them to you until you've failed 2, like Plaquenil, Sulfa, Plaquenil, methotrexate, and then you have to fail Arava. What does a remission mean? It means there's no cure for rheumatoid. Remission means that you are fine, you have no tender joints, no swollen joints, your quality of life is good, your fatigue is better. That's called remission. You're back to the way you usually were. That's called remission. You know, some people say, well, can I play the piano now that I'm in remission? I have to say, did you ever play the piano? They said, no. So then why would you play it now? You know? I mean, give me a break. You gotta... All right. I said, okay, hold on. Should we be... I'm not worried. You know what? My job is to advise patients. And taking biologics or any medication is called risk-benefit. It's a balance. So yes, they have side effects. But if you're going down the tube and you've got swollen joints, I'll guarantee 5 years from now you're not going to be the same person. You will deform, you will damage, and you will have a problem with quality of life. So I look at the risk, I look how the patient is, and I balance it to decide whether it's worth that risk to take a medication. I always err on the side of the patient, which means if they've got mild disease, I'm not going to jump into a biologic. If they have moderate and they're getting worse, of course. If they fail methotrexate, I will consider it. I am not particularly worried as long as I tell the patient what they need to know. And if I warn them about the side effects, I warn them about infection, all other things, that's the best I can do. And sure, some people are going to get sick on these agents. By the same token, I can go to bed at night knowing I've done the best for my patient. And that's what my job description is, doing the best for your patient. So that was a happy note, because that's true. And on that happy note, you know, your questions are great. I wish I could answer more of them, but I think I've helped. I want to thank you so much. Very few people fell asleep. I was really surprised. What did you put in the water? So I want to thank you so much for allowing me to come here and share this with you. The Arthritis Society is doing a great job. I want to thank the pharmaceutical folks who funded this tonight because it really makes a difference. So thanks very much.
We also have to thank our speakers, Mary Kim and Dr. Keystone. Thank you very much.
Thank you.
Great. And the last thanks go to our sponsors for tonight's event. Pfizer Canada as Health Champion, Hoffman LaRoche as Health Partner, Amgen Wyeth as Health Patron, and Abbott as Health Supporter. Thank you.